Okay, morning and great, ladies and gentlemen. Thank you very much for giving me a good opportunity at presenting this meeting. I'm very, very honored to be here. My presentation today, please start. My presentation today, the anatomy of tetralogical furrow. This is a very, very basic one. So not necessary to that senior surgeons as a cardiologist, just to the lavish. Please relax to that target to that the young surgeons and the young cardiologists. And also, very, very thank you very much, and Song Ho and Chan Ha, and great invitation is here. Okay, shall we start it now? So tetralogy of furrow. This is a constellation of the 4 anatomic regions in autopsied specimens. Why the autopsy? This one is all patient died before the ancient. So 1888, Dr. Farrow published blue diseases, including the VSD, overriding aorta, right ventricular outflow tract obstruction, right ventricular hypertrophies. The beginning of the treatment, just a Barlock Tausig shunt, not intercardiac repairs. 1944, almost 80 years ago. So 2 clever, great doctors established, combined with the Barlock Tausig shunt. Dr. Helen Tausig, pediatrician, and the Dr. Alfred Braddock. Why shaking? And also, he's at the very heavy smokers. Also, short tempers. Your surgeon is short tempers? I'm not sure to that anyway. So, Johns Hopkins University, this 1944 Braddock Tausig shunt. So, right subclavian artery cut off, and then pulmonary artery join again. Then blue baby, little bit recover to the pinkish. Baby survived. And please, this QR code, YouTube QR code here. Somebody to that put in a. This one is a very, very beautiful videos, BT shunt. This one is established Alfred Braddock, 1946, probably a beginning of the BT shunt. Very, very beautiful and BT shunt. I'm amazing to that more than 75 years ago, this operation is successful. I'm very amazing. But anyway, please show that. But please remember that Mr. Vivian Thomas, he's the great surgical assistant. He did so very great work, this BT shunt. But not much was talked about at the time, including his name, because his parents were raped. But he's that very good support, Dr. Alfred Braddock's successful this BT shunt. So many doctors this morning talk about conotruncal anomalies. Basic component is this yellow colors names. Ventricular infundibular fold, BIF. Outlet septums or infundibular septums. Septomarginal tuberculation, trabecular septum marginalis, septoparietal tuberculations, and also recently very, very important the subpulmonary infundibular muscle sweeps, very important for the Ross procedures. I talk after that. But please remember the young doctors, this name. Put on some, you write the diagrams. This name is very important. So probably 1 year after, I will check up that or testing. Okay? So things that lead to the confusion, that is a lot of problems. Do you have none this black label books, textbook? This one is a pathology of congenital heart disease. Dr. Anton Beckers and Bob Anderson published 1981. This is very, very confusion about that our surgeon is a cardiologist. The name is, what is the cluster? What the supraventricular cluster? And also conus. What's a conus? So various name is given different times in the muscular component. The trabecular septum marginalis before septal band. So, and also now is that the VIF muscle, ventricular infundibular fold, part of cluster and bulbo ventricular ridges, conoventricular phalanges, coronal free wall. Several talk about that, many different words. So surgeons and cardiologists, much confusion in this area. So usually to that you remember the basic anatomy of tetralogy furrow is the anterior superior deviation of outlet septum or infundibular septum. What's the anterior superior deviation? What is the deviation? What is the anterior superior? So a little bit confusion is as well. So you remember that these diagrams. Aorta is right side wall and behind, comparing to the pulmonary arteries. Pulmonary arteries, left side, anterior. You remember that. So outlet septum is these right lines, and the interventricular septum, IVS, is like a hook-like, these blue lines. Anterior deviation is outlet septum to the outlet area. And then pulmonary artery, squash. And then behind the aorta, little bit anterior side. So overriding the aorta on the interventricular septum, and also right ventricle outflow tract obstruction, some cases the smallest pulmonary valve as well. Under the developed pulmonary arteries as well. So subpulmonary infundibular sleeves, recently important anatomy loss procedures. Between the pulmonary arteries, the aorta, just behind the pulmonary artery, some muscle is here. We can cut this area for excise the autograft of the pulmonary artery. So surgeon can do the pulmonary valves, remove to that from the right ventricular outflow tract. This is one of the important components of the RVOT muscles. The normal heart, you put in a rise up right hand side. So thumb is the TSM, posterior extension. And also second fingers, this one. This is a TSM, anterior limb. And the arms, body of TSM. This is a very important right aspect of ventricles TSM component, anterior limb. But some textbook is a posterior limb, but my mentor said to the posterior extension. Posterior extension leads to the medial papillary muscles. So exercise to the supraventricular crest, just behind to the aorta is here. So surgeons much deeper bite of the sutures and the aortic valve salva, a little bit concerned about that injuries. And also angiograms. Remember the extent of aortic overriding of the right ventricular outflow tract. Repairs in the right ventricular angiograms frontal lateral views. Note the coronary arteries, sometimes the coronary artery very close. So I think that very important the angiograms or CTs than the echocardiograms in the cases. So landmark anatomy, BSD, between the anterior limb and the posterior extension of the TSM, just there. Divided outlet septums malaligned. Procedures, ostium infundibuli. Ostium infundibuli is the gate of the right ventricular outflow tract leading to the pulmonary arteries. So muscular outlet septum anterior deviation, the smallish to the RBOT's muscles. So building blocks in great colors, these pictures. So green colors and red colors all setting up. Outlet septum exclusively RV structure, not the interventricular structures. Please remember that. Not interventricular structures. RV structure, including the RV muscles. So, what's the BSD? BSD is the interventricular ventricular septal defect. Ventricular septal defect is sometimes confusing about the names. So malaligned, it means the overriding to the aorta on the interventricular septums. So blue color is the straightward to the interventricular planes. Green color, first or primary interventricular foramen between aorta and left ventricles. But surgeon closes at the second or secondary interventricular foramens. So we usually, what size of the ventricular size, it is very important to the LVOT is the primary interventricular foramens, but surgeons close at the second interventricular foramens. So sometimes to the DORBs, any another complex disease, you should describe about that which is which, primary interventricular foramens or secondary interventricular foramens, not only to the BSDs. So this hand signs is very important. So you just remember that in these sessions. Anterior superior deviation is the outlet septums. So outlet septums are left-hand side. And then infundibulum septums, and also trabecular septum marginalis, body and anterior limb and posterior extension is a BSD here. That is a malalignment. It means that outlet septum is a TSM anterior limb. It's a different planes. So various BSDs tetralogy follow. Perimembranous BSD and the outlet. Merkmal is the medial papillary muscle. Where is the medial papillary muscle is there? So muscular outlet, doubly committed, and the total constrict type. Why we know about this one? Because of that the conduction tissues. Perimembranous outlet, little bit close to the margin of the BSD. Muscular outlet, little bit away from the margin of the BSD. More away from that the BSD margins are doubly committed BSDs. So conduction pathway, I described this one. Perimembranous type is little bit close to the margin. So Merkmal is the medial papillary muscle. So where is the medial papillary muscle? And the muscular BSDs and the sub-arterial total constrict type. Recently, our cardiologist said, this is medial papillary muscle. Our cardiologist knows about the classification of the BSDs, perimembranous and medial papillary muscles here. 3D, amazing to the 3D echocardiograms, very, very useful for young surgeons' educations. And also, I'm a surgeon, and little bit shifted to the surgical point of view, and the closure of malaligned BSD. Malaligned, it means to the posterior malalignment and also anterior malalignment, two of them. So anterior deviation is a tetralogy fallot, is just infundibulous septums and also TSM anterior limb is different planes, and also coarctation type and posterior deviation is like that. So closure of the usually the membranous flap. Membranous flap, it means a remnant of the membranous septum. Membranous septum, it means to that the membranous side of the interventricular septum. So very, very important knows about the, this area, and also conduction system is away from here. So time is a little bit away, I just go. So how to close the BSD, the tetralogy fallot, and this hand sign again. So usually to anterior tricuspid leaflet, back hand up, and also BIF and the outlet septum is back hand up again, and then to the outlet septum is a hook, and also back hand up. Usually to the infundibulous septums, to the membranous flaps is a forehand ups. So surgeons do that like that anytime this one, or interrupted sutures. Sometimes continuous suture usually to the any another way. Probably another time I will talk about that. So away from here, and please remember how to close, and then today's take-home message, and this one, please remember that. Thank you very much for your attention.